Hi, chapter six then, to finish up for this week. Detox and healthcare needs, detoxification, healthcare needs, chapter six. So, detox may be seen as preparation for treatment. Some people, not in the field, but I mean the general public, some of them see detox as treatment. All you need to do is to get the drugs out of their system. They'll be clean, they'll be ready to move on. And you, of course, know that that's not the case. It's an important first step, and it's just the beginning of the process. In some cases, detox is not necessary. Obviously, it depends upon the substance and the level of use. If the drug of choice has been marijuana, someone's been using a lot of marijuana for a long time, while there's a withdrawal syndrome, a low-grade withdrawal syndrome from someone who has been become dependent on marijuana, there's no detox process to go through. The person simply stops smoking, deals with this low-grade withdrawal process, and then can move on. In other cases, of course, heroin, alcohol, depressants, other depressants, the detox has to be more carefully managed and is important. Heroin withdrawal, as an example, though, is pretty straightforward and relatively easy. It's been likened to a severe case of the flu. Can run from 4 to 5 to 7 days. Medical supervision is always a plus, but may not be necessary, may not be available in some cases with heroin. Alcohol withdrawal is another matter, should be carefully medically supervised, and medication can be used to aid in that, which we'll talk about in a minute. So the author suggests there's 3 tasks to undertake in detox. The first is to evaluate the detox needs. How severe is the use? What kind of care is going to be needed in the detox process? Secondly, important to stabilize the client during, obviously, and after the detox process is completed. You essentially want to continue the support at as high a level as possible. And then thirdly, to assist the client to transition into treatment. In other words, you don't want to lose him or her, right? So how serious is it? We've got to provide a stable support as he's coming out of detox, and then transition the person into treatment. That's the ideal world, right? Now, a lot of detox criteria have been established. The ASAM criteria are offered here. 5 categories, 4 different levels. Level 1 and 2, not as serious and may not need medical supervision, and can be done on an outpatient basis, residential recovery homes, that sort of thing sometimes. Again, depending upon the substance and the severity. Levels 3 and 4 calling for medical supervision. As a case study for you to look at this yourself, box 6.2 on page 87. So you take the criteria, apply it to this case, and see where you think, how you think this detox process should be carried out. The distinction is made here between detox in a medical model versus a social model, which is kind of what we've been talking about here in terms of how we're going to do this. In the social model, we've got no medical supervision. Again, this may be because of limited resources for a treatment program. It may be because there's no immediate access to medical care, and so it's a detox that's taking place under the supervision of non-medical staff, a social model detox. And you don't want to take this on unless you have no choice, but there are a lot of instances where this can be done safely with trained clinicians. In the medical model, you not only have the medical supervision, but you also may be able to use longer-acting substances or substances that can aid in the detox and aid in a continued abstinence. In the detox from alcohol, benzodiazepines like Valium are commonly used to sedate the client and to assist him or her through the detox process. In detoxing from opioids like heroin or painkillers, major epidemic right now as I speak in what is this, February 2016. Detox from those substances can be aided through medications like methadone, or with Suboxone, which is a buprenorphine and naloxone combined. And they will not only aid through the detox, but serve as maintenance drugs after the client is detoxed. So note on page 94 in this chapter, a comment about the clients knowing a lot about themselves. You got to remember this with people who have been, living the life of addiction for a long time, particularly around detox. Most of them have been through it before. They know what it takes for them to deal with their own detox. They know how long it'll take. They know how sick they'll get. And so we want to listen to them. Obviously, medical determinations need to trump that, but it's important to use that information that the clients can give you to help them and you through the detox process. Another box, 6.6 on page 96, gives you some withdrawal symptom examples from different drugs, and this may be new information for some of you. Now, also keep in mind that detox provides the opportunity for you to assist the client with other problems. Very few people come into substance abuse treatment or detox for substance abuse problems with only a substance problem. There are other medical problems. Some of them may be life-threatening, HIV/AIDS, or very serious medical problems like hepatitis. And so detox provides the opportunity to give the client assistance for those problems. So the fullest assessment in detox is going to include those other medical issues as well. And of course, psychiatric issues. Co-occurring psychiatric disorders are going to be very common. And so if you can identify those and help in the treatment of those once detoxed, that's of course going to be important. And remember that in those co-occurring situations, you want to do the detox from the substance first or concurrent with any other treatment, preferably first, because only then can you accurately diagnose for a putative co-occurring disorder. There may not be one. It may be drug-induced psychosis or something like that. And so if we detox from the substance first, we're in a better position to be able to assess what else might be going on. The revolving door of detox, people coming back and again to detox. And there are various reasons for that. In my experience in working in methadone maintenance, there were some who came for detox or brief maintenance because their heroin problem had gotten out of hand, and really all they wanted to do was to get clean so that they could start using again and not have to be using so much. It was too costly, whatever. Now, that's the most cynical way to look at the motivation, but that is in fact what some might do. There may be insufficient treatment slots, and so a person goes through detox, but when they're clean, they can't get into treatment, they go back to using, they relapse, they come back again for detox. So insufficient treatment slots is another reason. And then the third would be a fear or a lack of understanding of treatment. They don't know what it is, and they're reticent to do it, and so they'll detox and they split. So after detox, it's important to engage the client for treatment. And one way we do that is with this compassion and empathy we talked about earlier, checking to see what strengths they have, if they even know what strengths they have, and then what resources may be available, either resources they have, either internal resources or real resources, or other resources that you can identify to help them remain stable. So support and guidance in the absence of judgment. All right, empathy, helping to engage the client in treatment after detox. All right, bye-bye.